muy buenas tardes a todos. Gracias por conectarse con nosotros esta tarde de jueves 9 de mayo del 2024. Como coordinadora, junto con la doctora Julia Alberto y la doctora Catalina Bajes, les damos la más cordial bienvenida a nuestro webinar del Working Group de Obesidad de la Sociedad Latinoamericana de Gastroenterología, Hepatología y Nutrición Pediátrica. El día de hoy nos acompaña la doctora Sara. Le voy a dar la palabra a la doctora Ana Ayala para que lea su CV y le dé la bienvenida también. Y muchas gracias a todos por estar aquí.
Hola, buenas tardes. Muchas gracias por conectarse. Bueno, tengo el placer de presentar a la doctora Sara Karjoo. Ella es gastroenteróloga pediatra, egresada del Children's Hospital de Filadelfia. Es profesora en la Facultad de Medicina en la Universidad de Florida, en la Universidad de Morsani del sur de Florida también, y en la Facultad de Medicina de Hopkins. Está certificada en pediatría, gastroenterología y obesidad pediátrica. Actualmente es fellow de la Asociación Médica de Obesidad y su línea de trabajo principal es la salud metabólica, hepática, obesidad y nutrición pediátrica. Thank you, Sarah, for your time with us tonight. We are very excited to have you here and to hear the knowledge that you can share with us.
Great. Thank you so much. And thank you for having me. And I'm going to go ahead and share my screen and we will get started shortly. Give me 1 second. All right. So thank you and welcome this evening. My name is Dr. Sara Karjoo, and I am a pediatric gastroenterologist, and I'm also board certified obesity medicine specialist, and I practice at Johns Hopkins All Children's Hospital, which is based out of St. Petersburg, Florida. And I'm an associate professor at USF and at University of South Florida, Florida State University, and Johns Hopkins. And this evening, I am very grateful that I've been asked to come talk to you about obesity in adolescents and children, and to specifically talk to you about pharmacotherapy, as well as to talk about surgery in this age group. I want to thank the members of Last Begin for inviting me. And just to let you know, I am a paid speaker for several companies. I speak for Abbott Nutrition, Nutricia, and Ipsen. Our goals this evening are to recognize the current available medications for medical weight loss and treatment of obesity in adolescents, and the timing and eligibility of bariatric surgery in this population. As you know, there's been a lot of advances, and the American Academy of Pediatrics specifically came out with a very long practice guidelines in 2023. And in this, they have had a lot of updates regarding the medication treatment, but also the surgical treatment. And their definition of overweight and obesity has also been stated in this guideline. A child is overweight if their body mass percentile is between 85th and 95th. Anything above 95th is categorized as medical obesity. And then for class 2 and 3, there are significant percentages above that 95th percentile as listed in the slide. And one of the things is that you have to realize that obesity is not the same in every country. And when we look at obesity as a whole in the entire world, in 2020, about 14% of the world's population, adult and children, were found to have obesity. By 2035, there'll be 24%. That means 1 in 4 people in the world will be afflicted by the condition of obesity. There's a steeper rise in developing countries. And as you can see in the diagram, it depends on genetics, what's happening in the country economically, foods, culture. And so the reason is not the same in each country, and we must remove the notion that one treatment fits all people. And I want to argue that obesity is not, in fact, a person who may be lazy or inactive, becoming metabolically obese. Rather, it's pointing to a problem in that society. It's pointing to an imbalance that's occurring in a lifestyle and in that country. Well, let's look at country specific. And if you look with the country specific, in 2024, there was an article that came out to look at the percentages of obesity in several countries. When you look at Mexico, about 75% of adults were afflicted with obesity. It was more in women and more in urban populations. But when you look at children, it's more in boys, and it was more in rural areas. And as you can see, the highest areas are where the stars are. It's more in that northwest area, and more in that peninsula area was where the rates were the highest. Well, if you compare that to Chile, you can see that 74% of adults may be afflicted with this. Similar rates in the genders tends to occur, according to this article, in patients with lower education. But again, in children, half of children may be affected by it, but more in boys versus girls. Very interesting to look at the pattern. If you look at Argentina, about 68% of adults, again, more in women, more in certain socioeconomic groups, in certain lower education groups. And but in children, it happens to be more in boys. There's a different pattern, though, when you go to Colombia. When you go to Colombia, it seems to be, just like all the other countries, may happen more in women and adults, about 57%, but more in middle and high income citizens, peculiar. More in certain groups like Afro descent individuals. In children, about 22%, and it seems to be equal if they are at a younger age group, but when they hit adolescence, it tends to be more in girls. So in this country, it's not the boys. In Brazil, about 55% of adults may be afflicted with obesity, and they have equal rates in both men and women. About 30% of children have this, tends to be more in the South, more in boys, and more in individuals with a lower education group. So that's why when you look at this, you can't say, I have a solution for the entire group of Latin America or Spain. And if I didn't cover your country, I apologize. That article only covered those countries. But I'm sure you have to look and see within your country, what is causing it? And going to the root cause is really what's important. The other thing is that a lot of us as providers are uncomfortable talking about obesity. There may be cultural barriers. There may be perhaps, the feeling that the person is going to be offended by bringing this topic up. But rather, when they did do a survey, and again, these are an article that came out in 2024, they said that people do want to talk about it. They did not mention or bring a weight loss because they felt that the physician lacked the initiative to talk to them. Healthcare providers, we're the ones that are sometimes at fault. We feel that certain, not everyone, but certain healthcare providers feel like there's a lack of motivation, and that there's an obstacle to talk about this. In the AAP guidelines, they wrote that pediatricians are often the main source of weight bias. They're the ones that make it difficult. But when they asked the patients, 68% of patients with obesity said they would like their doctor to talk about it, to talk about treatment. And only a few percentage maybe felt a little insulted. It's how you approach it. So what are the treatments for obesity? And as you can see, it can involve nutrition, exercise, sleep, psychology interventions, medications, and bariatric surgery. And you do need all of it to get better. There's not just one solution to it. Tonight, though, we are focusing on medication and surgery. So we're going to proceed now first to medications for the treatment of obesity. Again, the 2023 guidelines came out from the AP, and they said that it is okay to offer pharmacotherapy for obesity and weight loss as young as 8 years of age or 11 years of age or older, with diet, lifestyle, and behavioral health intervention. So remember, no amount of medicine will undo a bad diet or lifestyle, but in conjunction with the therapy can be very effective. In 2024, a group of 10 experts from Argentina, Chile, Brazil, Colombia, Panama, Guatemala, Mexico, Ecuador, and Venezuela got together and came up with guidelines and consensus of medical pharmacology for adolescents and adults. Their current guideline is recommending phentermine, orlistat, liraglutide, semaglutide, topiramate, as well as other medications for the treatment of obesity. First, I would like to talk about orlistat. Now, with orlistat, it has been FDA approved and has been approved in Latin America for many years in children greater than 12 years of age. This medication works by inhibiting pancreatic and gastric lipase, and therefore it binds the lipids in the diet, in the gastrointestinal tract, reduces micelle formation, and the patient poops out the fat. The dose is 120 milligrams 3 times a day, given with the meal or 1 hour after the meal. And you have to be careful with vitamin malabsorption with this medication. So be aware of that. With orlistat, it can be used in combination with diet and exercise, but unfortunately, it only has very little weight loss. And the side effects are the things that prevent it from really being used by clinicians and patients. I put, about 5 of my patients on it, and within 2 weeks, all of them stopped it on their own because of the oily poop that they were producing. And so there's also other drug interactions as listed. So always be careful when you use this medication with the drugs listed below. When you look at phentermine, this tends to be more available in many countries. It is FDA approved in the United States for greater than 16 years of age. I do use it. For us, because it is a class 4 controlled substance, we do have restriction of usage for 12 weeks. We have to follow the state laws. We have to get consent from the parents. And of course, also it is used in Latin America with a lot of caution as well. In Latin America, you have to have a body mass index of greater than 30 kilograms per meter squared, or a BMI of greater than 27 kilograms per meter squared, and at least one comorbidity, as per the consensus article. This medication really targets the satiety centers of the brain. It is a sympathomimetic amine that goes to your hypothalamus and helps with hunger and diet and eating. And this does produce a moderate weight loss of 4% within 6 months. When you look at phentermine, there's many formulations. My typical starting dose, I start at 15, and I give it right. I find that it's more helpful if you give it right before lunchtime, but everyone has a different style. Some people give it right in the morning. I eventually, in larger adolescents, I do move it up to 37.5. I have also used the 8 milligrams 3 times a day before meals. I did not find that dosing to be as effective as the 15 or the 37.5 dosing. There's also the 18.75 milligrams that you can do twice a day before breakfast and maybe before dinner. But overall, it's an old school drug. It's been on the market for a long time, and it's available in many countries. But what I caution you is the side effects. What does it affect? The heart and the brain, mostly. So if you have a patient who has any mental health issues, please do not use it. It can really exacerbate anxiety in your patient. In addition, it does cause tachycardia and increases hypertension. So if you have somebody with high blood pressure, this is not the right medicine. It can also affect your eyes, glaucoma. So again, be very careful with those patients. And then of course, hyperthyroidism and any cardiac disease. So you have to, if you do use it, be very cautious when you use it. I wanted to also provide you with some examples of my patients on phentermine. So if you look here on the side that of where you see that the patient did not have as much weight loss, essentially right here, you can see that the patient started to lose weight a little bit, and then they had the weight regain. It's because we had to take the patient off the medicine due to our Florida state laws here in the United States. And then we started the patient back up and they started to go back and lose weight. I have another patient I gave phentermine, which is the one on the other side. You see his weight was very high, and then we started and he rapidly lost weight. And what do you think the difference was between different patients? Guess what? This one who had the most weight loss was compliant with diet and exercise. This one was non-compliant with diet and exercise. Medicines are not the only thing that helps your patient. So it does matter that they follow a good, healthy regimen. There's also phentermine and topiramate extended release capsules. This is now a new drug that's been marketed. So you don't have to give it separately. This is one pill and it has both medications in it. It has been FDA approved in Latin America and in the United States for greater than 12 years of age for a patient who has a body mass index greater than the 95th percentile. Compared to phentermine alone, when you add the topiramate, the weight loss is much greater than the phentermine alone. And remember, topiramate on its own has been used off-label in patients to prevent extra weight gain, like patients who are on antipsychotic drugs and they gain weight, they give them topiramate so that they don't gain more weight when they're on drugs that cause weight gain, or certain syndromes where they have hyperphagia. Sometimes the topiramate is given, but in combination with phentermine, it is more effective. In this drug formulation that is currently FDA approved in the United States and has both drugs together, you start at a low dose and you take it with food or without food. So you can see the dosing there. After 14 days, you can increase the medication again, and then in 14 days later, you increase the medication again to that dose of 15 milligrams of phentermine and 92 milligrams of topiramate. But remember, they have side effects. These medications affect the brain and the mood. When you add both of them together, you have the issue of depression and suicidal ideation, and all the other side effects of phentermine, which include the cardiac, the heart issues, the eye issues, the glaucoma, the hypertension, the thyroid, the renal issues. There's some kidney issues with this combination. So be very cautious. Good drug with good monitoring. So what about this medication? So this is a medicine that was approved in the United States in the 1950s, but really has fallen out of favor because of the side effects of it. In the consensus guideline, I found that interesting. In 2024, they did say that it is approved in Latin America for patients 16 and over for a total of 12 weeks if they have the obesity, and can be used up to 3 to 6 month course. Just like phentermine, this medicine is stimulating the dopamine and noradrenaline neurons in the brain and helping to induce satiety and to reduce hyperphagia and excess eating. In the studies, it shows about a 5 to 10% weight loss in 6 months compared to placebo. And it does help the other things, so glucose and cholesterol and LDL and triglycerides, blood pressure. The dose as listed, 25 milligrams 3 times a day before a meal, or just 75 milligrams once a day before breakfast. Just like phentermine, there are side effects of tachycardia, hypertension, arrhythmia, so cardiac side effects, and there's also issues with depression and headaches, so neurological side effects. Just like phentermine can affect people with glaucoma and can affect people with hyperthyroidism. So be very cautious with this medicine as well. But I'll tell you, there has been a revolution in weight loss medications. And a lot of the ones that I just mentioned to you have more about 4%, 5%, 10% weight loss, which is good, which is very good. But we have now medicines that are better. And these are the class of drugs called the glucagon-like peptide 1 receptor agonists. As you can see, those are some of the examples. And how do these work? What's interesting, they work by 3 mechanisms. Number 1, they go to your brain and they help with the hypothalamus and the limbic system, and they activate the POMC and the CART neurons. And what happens is it helps with satiety. Number 2, it goes and it delays your gastric emptying, so you feel fuller longer. But as gastroenterologists, we know one thing. Patients who are on this may increase your risk of aspiration for upper endoscopy and procedures. So be careful. If you have a patient on this medicine and you have to do an endoscopy, even though they don't eat at the appropriate hours that you tell them, don't eat this much before the procedure, they still have found in certain clinical studies that patients have retained food in the stomach, thereby increasing the side effect of aspiration. So it's good, it delays the gastric emptying, you feel fuller. It's bad, as a GI doctor, you gotta be aware you can have a risk of aspiration in those patients that you do endoscopy. Now, and then finally, it goes to the pancreas and it increases the metabolism and helps enhance the insulin secretion. So a lot of factors, 3 mechanisms why it works so good. And with those, it has side effects. I will tell you personally, I've had a patient that had pancreatitis. So it definitely causes pancreatitis. It causes gastroparesis and retained food in the stomach. The initial first 2 to 3 weeks, the patient has nausea. But what's interesting about this drug is after about 12 weeks, approximately, there's something called tachyphylaxis, meaning the body gets used to it and the gastroparesis improves. So patients who are on it for a longer period of time don't have as much nausea or have a lot of that symptoms. Patients can have altered bowel habits, whether it's constipation or diarrhea. There's also, you have to be very cautious with people with thyroid issues, thyroid cancers. You have to be careful with patients with kidney issues. It does cause hyperfiltration. And if the patient is not drinking water well, It can increase their creatinine. I've seen that as well. So good drug, but needs to be monitored very closely. Now, what are some of the examples? Which are the ones that are, now again, there are tons of those that we just talked about that are approved for diabetes, okay? And they will help you with weight loss. But there are specific ones that have been studied specifically for weight loss in patients who do not have diabetes and adolescents who don't have diabetes. The first one that got approved in 2020 was liraglutide, approved 12 years and over for patients with a specific body mass index. And in Latin America also can be used at 12 years of age as well. The doses have to be increased, but usually when you get to the dose of 1.2 milligrams daily, that's when you start seeing the weight loss. This formulation of GLP-1 is a daily shot. So something to think about. Not all patients like to get injections every day, but it is a daily shot. The drug trial that helped the approval is the one that I bolded. So there was a randomized control trial in 2020. And that found that daily injection over 1 year helped reduce the BMI by 5 to 10%. And the weight reduction versus placebo was 5%. In comparison, though, this is the big gun, semaglutide. And this is a longer acting GLP-1. The dose is 2.4 milligrams once a week. So they make huge difference. Patients don't have to get a shot every day. When it was approved, it was 2022. And for adolescents, 12 years and older with obesity, but not with diabetes. So it wasn't indicated for metabolic disease. And in Latin America, many of the countries have adopted the same policy as the United States FDA, and they have also approved the usage in patients 12 years of age and older. What was the study that helped this? So there was a double-blind parallel group randomized placebo-controlled trial. In this trial, there were the patients that were 12 to 18 years of age, and they were given the medication, semaglutide, 2.4 milligrams once weekly, just for weight management. And this was the one that caused the significant weight loss. So the mean change in BMI was about 16.1% with this medicine as compared to placebo. So remarkable. Everything else was 5%, 4%, 10%. This was 16.1%. And it also helped metabolic factors, waist circumference, hemoglobin A1C, lipids, ALTs, everything. Everything started to improve with this medication. I want to provide you with several examples of my patients on this medicine. Here's one example. I mean, you can see the top graph is the height. The bottom graph is, the bottom lines are the weight. And you can see how rapidly, but also how effectively the patient lost weight. Here's another one where I had another patient come to me for consultation as a PGI and obesity specialist for medical weight loss. We went over it, and mind you, all of this is being done with diet and exercise interventions for better sleep and psychology. So they can't get the medication until they promise me that they're going to do all of it together. And then here's another one. This one's an interesting one. I wanted to share this one with you. You can see the patient was, started out as, about around 8 or 9 is when they crossed the 95th percentile. By the time they saw me, their weight was very high. You can see that. And this is a patient that had social anxiety, gastroparesis, of course, medical obesity, and had metabolic syndrome. And the family came to me for consultation. I said, hey, you've got gastroparesis. This is a problem. But they were willing to try it. And I was actually quite surprised that the patient tolerated it and did very well, and it didn't exacerbate her gastroparesis. What the drug did do, besides weight loss, is it motivated her to be healthier. This is a patient that when I had been coaching her before the drug, she did not want to change her unhealthy diet. She refused to exercise because of social anxiety. She didn't want to look bad when she exercised. And she really was starting to cut back from her friends and talking to her friends. And what happened was, of course, we coached her, but she took the initiative to eat healthier. She enrolled in the gym and is actually still doing it. And she told me her win. She said, oh, I went out to the mall with my friends. I went to the store with my friends. I feel better. I asked her, why are you doing this when you were resisting before? She said, because I saw results. So patients with obesity are not lazy. They are frustrated. If you tell them to do a medical intervention and they don't see a result and they keep doing it, that's, Einstein said the definition of insanity is if you keep doing something and you don't see a change. So it makes sense why patients don't follow through on our recommendations. They don't see results. And what they're doing is not fun for them. So when they see results, then they will be more motivated to do the diet. Then they'll be more motivated to exercise and make those life changes. So I think medications are important. This, now we're going to shift gears. So we're leaving the GLP-1 medicines. This is still an injectable drug, but now this is a medicine for genetic obesity. This is setmelanotide, and it's an injectable drug that's been FDA approved in children 6 years and older, not yet marketed fully in Latin America. And this is for genetic syndromes which include homozygous mutation of POMC, PSCK1, LEPR, and both homozygous and heterozygous mutation of Bardet-Biedl syndrome. So again, this is for genetic obesity. The dose is 1 milligram daily, and then can be used, the most effective dose is 2 milligrams daily, but can be used up to a maximum of 3 milligrams daily in patients. What is this medication? What is this medication doing? So let's talk about it. So our adipose tissue secretes something called leptin. And that leptin goes to our brain and binds the LEPR receptor, and then goes downstream. So POMC neuron goes downstream and activates another neuron, the MC4R neuron. This neuron tells you you are no longer hungry. Stop eating. In patients with this genetic issue, that pathway is disrupted, whether it is the POMC component, the LEPR component, the PSCK1 component, as you can see in the diagram. One of those things is altered. The body doesn't get the signal. So what does the patient have? Hyperphagia. So they just keep eating. And these are the patients where the parents say, I have to lock the food away. They're eating, they can't stop eating. This medication, this new injectable medication, goes in between the POMC neuron and the MC4R neuron, as you can see, with these green dots in the middle, and restores the function. So it bypasses all the problems, activates the MC4R neuron, and gives you that feeling of satiety. Look at this weight loss. Remarkable. POMC, PCSK1, 25% mean percentage change in 1 year. LEPR, 12% mean percentage weight loss in a year. For BBS, that genetic syndrome where you can use it for a heterozygote, patients had greater than 10% body weight reduction after 52 weeks of therapy. I've used this drug in my patients who have the gene mutation, and I'll tell you, very well tolerated. The 100%, they're going to get hyperpigmentation. It's very interesting. Doesn't matter what their skin type is. They could be white as snow. They turn very, very tan. So that's one of the side effects, is that they turn a darker color. There's other side effects. There's one that says suicide. There's one patient that had a mental health issue before starting the medicine. We started it. They still, it kind of made them feel worse. We stopped it because of mental health. But besides that one patient, all my other patients tolerate it very well. This drug does pass into breast milk. And so for patients that become pregnant or are breastfeeding, you do not want to give this drug at this time to patients who are pregnant. So now you see that there have been quite a lot of advances in medications to help patients with weight loss and to aid in their plan with nutrition and exercise. And now there's medicines to enhance their success. Even though there's innovation, I have to say, to date, bariatric surgery still has the highest % of weight loss. It does. That's the truth. So let's look at this. So this is the updates from the American Academy of Pediatrics, as well as the American Society for Metabolic and Bariatric Surgery. It is recommended in adolescents, and loosely, they didn't really give a guidelines on the age, but the AAP has alluded to maybe they could do it at 13 years of age, but really most surgeons don't feel comfortable. In our area, we usually do surgeries starting at 16 if we need to. But theoretically, if you look at the guidelines and you read the articles, they did not give you a specific age. So it's up to your group, your society, your medical society to decide that. They recommend it for class 2 and class 3 obesity. Note that bariatric surgery does not negatively impact puberty or your height, linear growth. So therefore, you do not need to use a Tanner stage. You do not need to use bone age, and it's not required to get to a certain level before the surgery. In addition, if you have any syndromic obesity, developmental delay, autism, mental health issues, etc., it's not a contraindication to bariatric surgery in adolescents. The only contraindication currently that most surgery centers will reject a patient, at least in our area, is non-compliance. So if they get a hint that this patient will not follow through with follow-ups, medications, or anything, they tell them they're not ready, because it does involve a lot of follow-up and a lot of monitoring after the procedure, as well as before the procedure. So what are the 3 procedures that are currently in the medical literature that are recommended for adolescents? There's 3 of them. Number 1, in A, it is the Roux-en-Y, classic, been there for years. In B is the gastric sleeve, and in C is the adjustable gastric band. So pop quiz, which one of these is reversible? I'll give you a minute to think about it. Which one's reversible? I'll give you the answer. So Roux-en-Y is reversible, and the gastric band is reversible. It's important for me to bring this up because what's becoming popular now is gastric sleeve. So a lot of these centers in adolescents are doing gastric sleeve, a surgery that's not reversible in very young people. So something to think about. So again, the common procedures are the Roux-en-Y and the gastric sleeve. Prior to 2010, Roux-en-Y was the predominant procedure, hands down, everybody, adults, peds. Now, in adolescents, gastric sleeve is more commonly performed. Generally is an easier surgery, maybe the recovery is better, but note that it's not reversible. And what's less popular and really honestly fallen out of favor and nobody's really doing it, let's be honest, is the adjustable gastric band, because there's side effects of perforation and you have to adjust it, and there's a lot of revisional surgeries, and because of that, it is not recommended. At this time, although there are other endoscopic bariatric surgery, these aren't approved in adolescent, and I'm not going to talk about them, but stay tuned. People are looking at gastric balloons. People are looking at, different devices. So there's tons of innovation that's occurring, a lot of it more in the adult side, but I'm sure at some point it's going to show up in pediatrics. What are the adverse effects of metabolic surgery? Well, the very, very basic is malabsorption. We know that as gastroenterologists, that if you manipulate the gut and you medically give a patient short gut, essentially what we're doing is producing controlled short gut syndrome. And so patients will have malabsorption of B12, iron, calcium, and vitamin D. When you do bariatric surgery, you increase the risk of that patient, that child, that adolescent to have fractures in their lifetime. And the decrease in bone mineral density can happen up to 2 years after the surgery. So something to think about. Now that people are doing gastric sleeve, you have to be careful with that, because as a GI, you got to remember, when you have increased pressures in that small stomach, you're going to have more reflux. You're going to have more chances of Barrett's esophagus. You can get Barrett's esophagus as a teenager. I've seen it. So one of the things is that it increases the risk for certain issues. You have to be aware of it. You have to monitor them and take care of those issues when they arise. But what are the positive outcomes for bariatric surgery? They have the weight loss that they need to improve their metabolic condition and potentially their fatty liver and their fibrosis, right? So if you look at the data 5 years after Roux-en-Y, 2 of the studies I put here, the AMO study and the teens lab study, they had a percentage total body weight loss of 26 to 28%. If you look at the FAB S5 plus study, 8 years after the Roux-en-Y, patients had 29% loss. What about gastric sleeve? Gastric sleeve in the teens lab study, they had lost about 27% total body weight reduction. And all of them had, of course, decreases in body mass index, very significant decreases. So good medical weight loss that will help the metabolic syndrome. Bariatric surgery is safe for adolescents. Overall, that's the consensus, even though there's some side effects. And when they looked at the metabolic data from the teen lab, and I encourage you guys to read that article. It's a very good article. They found that as compared to adults, there was improvement in cardiovascular comorbidities, type 2 diabetes, and hypertension, far better than adults. And you say, well, Dr. Karjoo, why is that? They both got the surgery. Why are the adolescents getting better? Because they've had far fewer years of, end organ damage, far fewer years of having this issue without being taken care of. So they have less problems, and they recover quickly, and their metabolic condition gets better much, much faster. For us as gastroenterologists, as PGI, what's interesting is bariatric surgery does improve steatosis, and it does improve steatohepatitis, and may even resolve liver fibrosis in a portion of patients, about 30% of patients. What's the surgery that helps the most with MASLD? The Roux-en-Y. So they have that data that shows that the Roux-en-Y helps a lot with MASLD histology. So guys, I took you through a journey through medications and surgery and the treatments in adolescents. Let's talk about the big punchlines. Number 1, the rates and causes of obesity are different in different countries and different genders and different age groups. It is a factor of what's happening in that country that's causing the obesity. It shows that there is an imbalance that's happening in that society. There are a lot of new weight loss medications in adolescents that are used in conjunction with diet and lifestyle. These may include orlistat, phentermine, topiramate, amphetamine, liraglutide, semaglutide, and setmelanotide. So all of these drugs have been used for medical weight loss. Gastric sleeve is now the most common metabolic bariatric surgery in adolescents, has equally good results as the Roux-en-Y, but not reversible. You have to make sure that you follow adverse effects. Bariatric surgery still has superior outcomes in weight loss compared to medical or medication therapy, and has significant improvement in cardiovascular comorbidities, type 2 diabetes, masled MASH, hypertension, as compared to when you compare the data to adults. And you have to be aware of adverse effects of surgery. Malabsorption is key. I've listed the vitamins there. Bone fractures, severe reflux, Barrett's esophagus, especially with the gastric sleeve. You got to be careful with the reflux. I really appreciate your time this evening, and I'd be happy to take any questions. I have listed my email if you have any questions and or would like to collaborate, and would be happy to take any questions at this point. Thank you for your time this evening.
Thank you, Sara. We are really excited about all the things that we listen. We have several questions here. I'm going to start with the first one. So the first one is, how long after the start of the conventional treatment, that is diet and exercise, you can think that is failure to this kind of treatment and you need to consider to start medication? And also, in what conditions you need to start the medication for the first step?
Beautiful. Okay. So there are two ways you can do it. I know a lot of my colleagues start with diet and exercise first, and then they go ahead and they consider medication. And my rule is, and I practice differently. Initially, when I was doing this, I said, well, I'm going to give them 6 months, and then I'm going to offer them other things. But since the AAP guidelines came out, and there has been a shift in the obesity world, that you offer all of these things in the beginning. So do you know what I do? I don't choose for my patient. I don't know what they're thinking. So when I go through my initial assessment and I ask a little bit about diet, and these are long visits, it's like 45 minutes. But when I have, So when I go through these and I evaluate the patient, I look at diet and lifestyle, I look at sleep, exercise, motivation, psychology. And in the first visit, when I meet the patient, I talk about medications. And I say, what medicines are you taking that cause weight gain, number one? And then I also ask them about, are they interested in medications in the future? And then I also bring up surgery. And I say, this is the guidelines. They say that you may have surgery. And then I get a feel for the patient. I see, where are they coming from? And you'd be surprised if you just ask. You're not choosing for them. Just ask, this is what's available. They tell you. One of them says, I will never do surgery. I will never do medicine. I've had patients that come to me and said, I'm glad you finally asked me. I have done this. I came to you because one of them said, I want surgery tomorrow. I said, okay, let's slow down. So I have changed my practice style, and I give that option from the first visit. I talk to them and say, and then if I don't think it's appropriate, I say, although this is what I think, I don't recommend it right now. Let's work on this. But the conversation starts because I want to know, where is the brain of that patient sitting there? What are they thinking? And I make it normal so that they feel comfortable to tell me everything. I hope that helps.
Yeah, thank you. Well, maybe here in Latin America it's a little bit different because we don't have a lot of options here, but it's a good thing to see that we have a lot of options and we need to consider everything.
And everybody should make their own style. You know, nothing is really set in stone. If you think you want to do diet and lifestyle for 3 months, 6 months, and then you want to do other things, that's perfectly fine. But I want to give you a joke so that you can think about it. If you have a patient with asthma and they come to see you, right? You say, hi, you have a patient with asthma. Then you say to them, okay, first you have to take deep breath and exercise. And then I see you in 3 months. If you fail the deep breathing for your asthma, I give you a puffer. You don't do that. You have asthma, I give you a puffer, so you do it as needed. We have a different viewpoint about obesity. We say, oh, we can't do it. And then we wait later when they fail. But by that time, the patient has lost hope and has frustration, and they look at you like, why are you torturing me? So that's why it's important to have the conversation early and see where the patient is.
Thank you.
Beautiful. Beautiful. We have another question from Dr. Jorge Chavez. He asks, what do you think of the apple cider vinegar study in adolescents, which report the same weight loss as semaglutide? It is promising?
I would have to look at that. I've had a lot of patients who come to me looking for natural remedies, and I would have to look at that. I have doubts on that sort of data, but send me the article. Let me look at it, and I'm happy to talk about it offline.
Perfect. Thank you. We have another question.
We have another question. It is possible to use a gastric balloon in adolescents. It is not about medication, but maybe you have some experience about it.
Yeah, so very interesting.
Oh, wow.
So I've definitely been looking at this. There is one physician, a group in Harvard, Boston, and I met them. They're pediatric GI. They're so cool. They're doing studies of gastric balloon in adolescents. So unfortunately, I missed that bandwagon. I was thinking about it. I think it was about 8 years ago, and I went to Hopkins, and we were trying to get grant. I actually even spoke to several people in Stanford, and we're like, let's do a multi-center study. But we felt, and I think Mayo even may have done a study, but stopped it because there was a lot of side effects. So when we found out there was a lot of side effects, and the Mayo study did not do very well, because when they put it, the patients had a lot of nausea, and they had to endoscopically go and remove it. That's why it hasn't progressed, because of the side effects. But the group in Boston Children's and Harvard, they are using it in adolescents. And I think they're gonna probably at some point publish their data. And I think that might be an avenue for pediatric gastroenterologists to use that. I'm curious to see what their data shows, but yes, they are looking at this. I don't personally do gastric balloons. I don't have that expertise. I'm excited to learn about it, but I think stay tuned and let's see what the data shows.
Thank you. We have another question here from Andrea Huerta. In pediatrics, we always invite the whole family to change diet, and of course, it's difficult. In your practice, what is your recommendation? He's from Mexico City.
Yeah, I feel you as a colleague. That is the one thing that's very hard, because it's the family dynamics, right? And that's when I ask them, I ask them about their motivation of the child. I ask them, and I ask the motivation of the family. And I say to them straight out that they're not just changing the diet of the child. It has to be the diet of the family. And we talk about I do something called SMART goals. If you Google it, SMART goals in the US, it's kind of a psychology thing. So it's specific, attainable, measurable, reliable, time-based. So I don't tell them what to eat. I say, these are your nutrition goals. You need to do these to be healthy. And you choose and you create the SMART goals. So then they sit down, They say, I will, as a family, do this, 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 and this. And I do find that even those who don't have as much motivation, they will make a goal. And when they choose to do it, it's more effective than me saying, go eat this, go do this. So the rule is, however you do it, they have to make the goal. And you have to emphasize it's not the child. And you have to emphasize, well, you're buying it for the child, or you're making it, and you do talk about that family structure. And this may be multiple visits. There may be one visit that you're just talking about making that goal and that structure for food. Then you bring them back. Next time, today, our goal is to talk about exercise. Then you do this. You can't do it all at one day. You got to keep bringing them back. My cadence is I bring them every month. So, and then we make an event, and they come back. When they're motivated, they come back. So.
Perfect. We have another question. Livia Machado said, if there is no problem with surgery and with linear growth, and then say it is possible to reduce, and I'm sorry, that you say it's possible to reduce bone marrow obesity. Could you explain more about this regard?
Yes. I think there was a radical change in the Bariatric Surgery Society and the AAP. And they wrote their language in their guidance in their article so that restrictions of patients who need medical bariatric surgery are removed. Okay. So if you have a patient, I'll give you an example. 14 years old. Oh no, 13 years old. But the patient, and no joke, I have a patient that has, I saw this week, 400 pounds. So 400 pounds in kilo, 181 kilo. Okay. So I'm going to do medication, diet, lifestyle. But that patient has, hypertriglyceridemia. The advent of diabetes is going to happen. They're having sleep apnea. And if I can't get the weight off this person, that is a medical problem. So at 13 or 14, they might not be fully developed, but they are allowing that doctor to recommend bariatric surgery. And many of the times when you do send them, the surgeon works with them for 1 year. They don't do it immediately, every one of them. They work for 1 year, they go to their nutrition program, they go and they have social workers, the structure of a multidisciplinary bariatric center. And then eventually, if they're a candidate, they're compliant, then they go forward. And during that period of time, many bariatric surgery centers, which is not recommended anymore, but they usually say you have to lose a certain amount of weight before surgery, or you have to be on vitamins to address malnutrition before surgery. So that linear growth and puberty restrictions have been removed. And they don't, I guess in the studies, they found that it doesn't affect that patient's potential for growth. But let's say you do surgery, now they're 16. You do surgery, they lose weight, all their issues are better. In their lifetime, they have a risk of osteopenia. They have a risk of malnutrition, malabsorption. If you did a gastric sleeve, they have reflux, right? You have all these things you have to think of, and you have to follow them, whether it's a primary or a GI or a bariatric surgery center, they can't just be sent off. And many of these patients, they have weight regain in 2 to 5 years, not to the point that they were, but they gain weight. Does anybody here know? I'm going to see if anybody knows, why do they gain weight after bariatric surgery? You guys all know it. You're gastroenterologists. See if you know.
I think that because the stomach returned to the initial measurement, maybe. Yeah.
I love it. Andrea Puerta, intestinal adaptation. Yes, short gut syndrome gets better. The human body is always trying to fix itself. That's the thing. So there's always an adaptation, so they gain weight again because the body's like, oh my God, I had loss of intestine. Let me fix it. So there's adaptation. So then now in the obesity conferences, now they show, okay, weight regain. And then guess what happens? Then they have to start medication again to lose weight again. So that's normal.
We have a last question. We would love to talk about obesity all night long, but at what dose will you start semaglutide for the treatment of obesity, and what labs will you ask for follow-up?
Okay, so for I think I have a nice Excel sheet of patients I'm doing. I have approximately, I think 15, 17. I have a good number of patients who are on the medication. The ones that I offer, often, even though I offer it, I told you, I tell everybody, this is a medicine, you're 12 years old and older, this is your option. But the majority of patients who take me up on starting the medicine are 14, 15, 16, 17, etc. When I offer, as you know, the one that I use is the one that goes up by every month. So it starts at 0.25, then it goes to 0.5, then it goes to 1.0, then it goes to 1.7 milligrams, and then 2.4. And because there was not really much of a guidance on laboratory or things like that, there are some, but when I was first starting the medicine, I was really worried about pancreatitis, I was worried about thyroid, I was worried about all these side effects. So in the beginning, and I still do, because I've found it does help. Once a month, I get labs. I check on them. And again, this is me. There's no guidance. This is just me. Know that this is not a guideline. I check the fasting insulin, lipase. I check GGT, hepatic function, hemoglobin A1C, lipid panel, thyroid panel. And it's interesting. Nobody's looked at this, but when I've done this and I notice, for example, the lipase is going up, I don't increase the dose and the patient is losing weight. And so I actually think that there is a role to monitor closely for side effects. And if you see it, I have sometimes had great effects at 1.7. I don't go to 2.4. I have some that I go to 2.4 and then they get the really bad constipation or the really bad reflux, or they have, some of them have mood changes. They tell me, like, I don't feel good. So then I go back down. And as long as they have good weight loss, I keep them at that level. And I've found that not a lot of adolescents, even though the study put them at 2.4, not a lot of adolescents need such a high dose like 2.4. I can keep them at 1.0, 1.7, get a similar result, and gives me chance to move up if they have plateau. So that's the experience that I'm having. So I hope that answers your question. And again, I provided you with my email and I'll go ahead and type it. If you have any questions, I welcome them. And I can talk offline to anybody who wants to, has questions about these medicines and what, our experience. So.
Thank you so much, Dr. Sara. We want to say thank you for your time, for those previous meetings. Thank you so much for this time with us, and thank you for your magnificent talk. Queremos agradecer realmente a todas las personas que lograron conectarse. De verdad, muchísimas gracias porque, fuimos testigos de esta plática tan interesante y sabemos de repente que en los países de Latinoamérica no tenemos tanta oportunidad de tener estos medicamentos, quizás 1 o 2 dentro de las pláticas que teníamos previamente, pero creo que esto viene a ser muy enriquecedor para el conocimiento de todos de cuántos medicamentos más podríamos tener en cuenta que se podrían utilizar en el tratamiento farmacológico de la obesidad. Así que mil gracias a todos por su tiempo, por haberse conectado. Tuvimos una muy buena audiencia y las preguntas que quedaron pendientes vamos a hacerlas llegar a la doctora Sara para que podamos realmente tener sus respuestas. Así que muchas gracias a todos, buenas noches y que tengan muy buen fin de semana que ya casi llega.
Thank you, everyone. Have a
Thank
good
you. Thank you. Thank you. Have a good night.